Well, so if you look at the tricuspid valve, it's no longer a forgotten valve. At least moderate tricuspid regurgitation occurs in greater than 1 in 200 persons in the general population and 4% in 75 years or older. And the 5-year survival is actually less than 30%. So it's something important. Now, causes of organic tricuspid regurgitation are multiple, as you know, rheumatic valve disease being very important, infective endocarditis, and Loeffler drug-induced, radiation-induced. And this just to show you that three-dimensional echo is very useful because most of the time you can look at all the three leaflets of the tricuspid valve as shown here. You can see the anterior, posterior, and septal leaflets of the tricuspid valve very well here, and also below it. And let me go to the next slide, and if you can play that. Here again, if you take a look at this, here is the left ventricle, and you can see all the three leaflets very well. And of course, now we know that some patients may have 4 leaflets, some patients may have only 2 leaflets, so that can happen. As a matter of fact, some original research came from Chennai, from a surgeon called Victor Solomon. He was not only a cardiac surgeon, he did his FRCP, but he was FRCS, but he also his degree both, like he had MD in surgery as well as MS in surgery as well as MD in medicine. And you might remember him, Dr. Allegation, Victor Solomon. Yeah, very good surgeon. His wife and my wife were together residents in geriatric medicine in London, and that's how I came to know him at that time. So he always thought that the tricuspid valve was actually a 2-leaflet valve, and the third leaflet is really a part of the second leaflet. Now, everything has changed. Sometimes it's 2 leaflets, sometimes 3 leaflets, sometimes there are 4 leaflets. So just to give you some idea about this, and here again, one can see this is rheumatic tricuspid valve stenosis here, and this one here, and then actually when the valve closes, you can actually see a hole also, a defect in the tricuspid valve. So 3D TTE is really very, very important in these patients. And I think you can play this one. And here is the apical 4-chamber view. All you do is come down from the top, and one can see not only the mitral valve with mitral stenosis, with no commissural calcification, but you can also see all the 3 leaflets of the tricuspid valve. And one can see that the septal leaflet is not moving that well, while the posterior leaflet, this is the posterior, this is the anterior here with the outflow legs, and the anterior leaflet is moving very well. So is the posterior leaflet, but the septal leaflet is not moving well. So one can exactly get an idea of what's happening with these tricuspid valve in these patients. And this is just to show you that little thing. I mean, again, a defect in the valve goes very quickly, but once in a while you can see a hole in the valve very clearly here in that tricuspid valve here. So let me go to the next one here, and go back. Here again, with the 3D is so good in some of these patients. For example, you can see the site of chordae rupture actually in the tricuspid valve. This is the left ventricle on this side, right ventricle here. You can see the chordae rupture very clearly here. And I think you can play this one here. And here again, you can see a flail tricuspid valve very, very clearly using 3-dimensional echocardiography, because you can go in and out. You can crawl from the top and from the side, and one can see it very well. Here is another patient. You can play this one also. And so these are all causes of organic tricuspid. Here you can see the chordae rupture exactly where it is very, very clearly in this patient here. This is a patient with papillary muscle rupture on the right side. And if you I don't think we are going to play this, but you can see a very large flow acceleration of the huge vena contracta here. So one can see that very clearly. You can play this one. And yeah, you can see that this is the papillary muscle, and the papillary muscles on the right side are small, and one can see very large vena contracta here. You can play that again here, and see the papillary muscle prolapsing with the torrential tricuspid regurgitation. So very, very well. And this is actually, if I go back, this is Epstein's anomaly. And again, in Epstein's anomaly, we frequently talk about the displacement of the mitral and tricuspid. It's not really that. It's really a question of how much of the tricuspid valve is really plastered to the septum and to the wall of the right ventricle. And here you can see the septum leaflet. There's a plastering of the wall, so that there is a restricted motion of the septal leaflet in this patient with Epstein's anomaly. Here again, this is LV, this is the septum, And here you can see the plastering motion where this attached here. So this is really the real pathology of abscess anomaly, not apparent displacement of the mitral and tricuspid valve, as we have been taught in various textbooks. Now, this is functional regurgitation. Of course, the major reason for functional regurgitation would be primary or secondary pulmonary hypertension causing RV, RA, and tricuspid annulus dilatation. And of course, you can have RV cardiomyopathy, stenosis of the pulmonic valve. Left-sided pathology is very important, where you have LV dysfunction, different mitral aortic valve stenosis, resulting in pulmonary hypertension and tricuspid regurgitation. So primary or secondary pulmonary hypertension, including left-sided pathologies, and of course there is a congenital left to right shunts also. And very important now, coming up now, is not only chronic atrial fibrillation, but isolated tricuspid valve annular dilatation may cause tricuspid regurgitation here. So how do we estimate the severity of regurgitation? One is to look at the maximum two-dimensional transthoracic echo color Doppler tricuspid regurgitation jet area over the right atrial area greater than 35%, or some people say greater than 50%. That would go for severe tricuspid regurgitation. Very important, you make sure the Nyquist limit is greater than 50 centimeters per second. Usually we keep it about 60 to 69 centimeters per second with the new machines. And also make sure the color gain is properly adjusted. You increase the color gain till you get noise, and then reduce it till the noise just disappears. If you don't do that, don't use any area method for mitral, tricuspid, or any other regurgitation. Nyquist limit and color gain are very, very important. The people who made the guidelines in the beginning did not read our papers thoroughly, and did not mention anything about Nyquist limit. Only now they are mentioning, but now not very well mentioned. But if you don't do the Nyquist limit, you are not going to get any good results. So that's very important. This work actually was done by none other by Dr. H.K. Chopra when he was a fellow in our echocardiography laboratory quite a while ago. And this work was done, and this work is still very current and still being used even now. And of course, if it is a 2DT, you cannot actually look at the tricuspid jet area or the right atrial area because you don't see all of the right atrium. So in that case, just go for the maximum 2DT jet area. If it's more than 10 square centimeter, that would be severe tricuspid regurgitation. Very important is also to look at the vena contracta by 2DTT greater than 7 millimeters or more than 7 millimeters would go for severe tricuspid regurgitation. Now remember, when you look at the vena contracta, that simply means a hole in the tricuspid valve or defect in the tricuspid valve through which regurgitation occurs, and you are only getting 1 or 2 dimensions by 2D echo. If you go for 3D echocardiography, which I wrote down here, then you can see the whole area. You can see the area of the hole, and if it is greater than 0.75 centimeter square, that would be severe tricuspid regurgitation. It's more than 1 centimeter square, it's torrential. So very easy to remember. More than 0.75, more than 1 square centimeter is severe tricuspid regurgitation. One can use a PISA also, but the PISA has a major problem because you assume that the hole is actually elliptical in shape, when exactly it's never elliptical in more than 90% of the patients. So PISA has got a big limitation, but PISA has been used more and more everywhere. We all use PISA all the time, but it's really not good. And there is some recent data on tricuspid valve where they put clipped the tricuspid valve for reducing tricuspid regurgitation. They think that 3D vena contracta is better than going into 2D or 3D PISA method. So that's very important to remember. Now, there are some newer, now another person, Dr. Han, who has done a lot of work on tricuspid regurgitation, has come with some new classification where she says that severe tricuspid regurgitation means 3D VCA, vena contracta, or of course quantitative effective regurgitated orifice area. If it is greater than 1.15 centimeters square, it's torrential. Our method, which we did originally by Dr. Dasan from Kerala, he showed it is more than 1 centimeter. So 1 and 1.5, 1 and 1.15 means nothing. So the new classification is same as our classification, essentially, really speaking. So there's hardly any difference between the two classifications which she has proposed, where we put up a 3D VC quantitative, more than 1.15, and here again they said more than 75, and we had the same classification. So really is the same as our. And this is the work, original work by 2D echo done by Dr. Chopra and Dr. Fan from a laboratory, and this is by Dr. Vilayudhan Dasan from Kerala. who did the work on 3D echocardiography, looking at the vena contracta by 3D echocardiography. And you can see the vena contracta is not elliptical, it's sometimes very irregular in shape. So PISA method is really not as good as 3D vena contracta. I think you can play this one. This movie is from Dr. Dasan, Vilauden. And here what we are doing is grabbing it in 3 dimensions. And here is the flow acceleration, there's a jet. So in between would be the hole in the valve. So place your, come down and crop it right at the level of the leaflets, as we'll be doing it right now. I'll show that. We can actually take out even the 2D to even more to clarify it. And you can come down right at the level of the leaflets here. That's where the hole in the valve is. And then once you do that, you enfase it. And once you enfase it, all you have to do is to planimeterize it. And if it is more than 0.75 square centimeter, severe tricuspid regurg is more than 1, or if you want to call 1.15 square centimeter, is torrential tricuspid regurgitation. You can see it's a very irregular shaped vena contracta here in this particular patient here. So that is another way to look at it. Very important, as has already been stressed, always make sure all these methods work very well. If the tricuspid regurgitation is pansystolic, but you may have patient with tricuspid prolapse, and as you can see with the continuous wave Doppler, this early systole is missing here, early to mid systole. So tricuspid regurgitation occurs only mid to late systole, and here again you can do that by color Doppler. So always do color Doppler or continuous wave Doppler, basic better color Doppler anytime we are looking at mitral or tricuspid regurgitation. For example, here you can see that early to mid, there is no regurgitation, only in mid to late systolic. So in this patient, tricuspid regurgitation, if you think by vena contracta is severe, may not be really that severe. So in a patient like this, you really have to go ahead from vena contracta. You have to keep on go ahead and measure the actual regurgitant volume, and that will be lower. So most of the time we don't measure the regurgitant volume, we just go by vena contracta, but make sure the tricuspid regurgitation is pansystolic. If not pansystolic, then you have to go back and calculate the exact volume of regurgitation. And 2, 3, 4 minutes here to look at the mitral clip has been used for same mitral clip has been used to tie together one or two leaflets of tricuspid valve to reduce tricuspid regurgitation. Now, of course, you have TriClip, which actually edge-to-edge repair has been done. And let me show this one here again. And but then so many other leaflet coaptation devices. You can put a spacer here, like you can do here. You can actually do annuloplasty in the cardiac catheterization laboratory, as you can see that here. And here you do the clip here to clip the 2 leaflets of the tricuspid valve. And so quite a few devices have been done. And one of the device, I know that I have it here. Let me go back here. One of the device is to put 2 valves, one at the junction of the IVC and right atrium near there, and another one near the junction of the SVC and right atrium. So you don't really interfere with the tricuspid valve, but you prevent the backflow into the superior vena cava and backflow into the inferior vena cava. And that has come up also quite a bit. It was not coming up very well, but recent data shows that works also very well. So you don't touch the tricuspid valve, put the valve in the superior inferior vena cava near the junction. So that's another thing. And of course, with the clip has been very good results. PR reduction achieved in almost 87% of the subjects in 1 year. And there is some follow-up data also shows effectiveness of tricuspid edge-to-edge repair here. Also, how about orthotopic tricuspid valve replacement? Now, that has been done. Indications are if you have a large tricuspid valve coaptation gap of more than 6 to 8 millimeters, the tricuspid regurgitation is non-central. It has got poor tricuspid valve repair success, so you can go for tricuspid valve replacement. Also, when it comes to organic causes like tricuspid valve stenosis, calcification, etc., extensive pacing lead interacting with tricuspid valve, abstinence anomaly, endocarditis, etc., then you go for tricuspid valve replacement here. Here to show you one patient with a lot of gap between the leaflets of the tricuspid valve. This will not be a good case for repair. This is a good case for replacing the tricuspid valve itself. And there are different valves which have actually been used to replace the tricuspid valve, including the valves which have been used in the mitral position, valves which have been used in the aortic position have been actually used in the tricuspid position. The major problem is that when you go for clip, you are reducing the degree of tricuspid regurgitation from severe to mild to moderate. But when you go for valve replacement, you are completely getting rid of tricuspid regurgitation, and the ventricle, when that happens, cannot tolerate that. So some of these patients immediately go into acute right ventricular failure from increase in the right ventricular pressure overload, since there is no post-op tricuspid regurgitation. Now that's a big problem. So because of that, we now are very careful that we look at the pre-op RV function using various methods that we have, TEPC, fractional area shortening, and also right ventricular global longitudinal strain. And hopefully with that method, we'll know that the RV may not be functioning very well. So these may not be very good candidates for tricuspidal replacement. So because this is a very problem, tricuspidal replacement is acute right ventricular failure occurs. So that is one thing which comes up. And of course, we have 3D printing now. So one can individualize exactly what valve to put in and how to repair any particular patient, because you can print out, do a 3D printing, which is individual. So I think I've taken quite a bit of time. Thank you very much for your kind attention. Any questions? I'll be glad to answer.